Besides being a well-published author, he has been working on drug-resistant tuberculosis in Romania since 2006, and his experiences include staying in a sanatorium and interviewing hundreds of patients and drug-resistant TB care providers in order to understand people's experiences better. And he also consults for has consulted for various NGOs, including the WHO, and he's going to talk to us about the clinical considerations and consequences concerning drug-resistant TB treatment, hearing loss, and access to new drugs.
Thank you very much. So I'm a medical anthropologist from Wayne State University and sort of a researcher who became an advocate largely because what I saw from my research was that there was a massive need for this. And this slide you see here, the title slide, is actually where I lived for about 6 months during my 5 years of research in Romania. And while I was living in this sanatorium, what I found was it was really hard to do qualitative research because a lot of the people were partially deaf. So since 2012, this has been something that I've been really concerned with and have been thinking about, because what I've seen is that if you don't necessarily notice how bad this problem is until you have a long duration experience with people affected by TB. So in addition to interviews and all the normal sorts of methods, anthropologists use participant observation. And what that means is we spend a lot of time with people. And in many cases, I knew people from the moment of diagnosis, sometimes before, all the way through years after they completed treatment. And I got to see what happened when they were deemed cured and exited the medical system but were no longer whole. So what I'll share is the experience of one man who I met while I was doing this research. This was in 2013. He was diagnosed with XDR-TB. He was a young man in his early 20s with shaggy hair and freckles. And in his first year of university, he was studying engineering. He found that he had XDR-TB and had to drop out of school, move to the capital for treatment, and he was lucky. He had good access to treatment. Even though he had XDR-TB, though, he still received the injectable. He also received linezolid and Bodacla, and he was very lucky to be able to do that. But the injectable made him start to lose his hearing, but he didn't realize this until after treatment was over, when he returned back to work. He was working in a supermarket, and there's a chime that goes off when they need more cashiers to go to the front of the store, and he couldn't hear it. And the managers thought he was lazy. He was worried about losing his job. And he wrote to me one day and he said, what should I do? I can't hear the sound that I need to do my job, and I'm ashamed. And if people find out that I have this problem, they'll think badly of me. I might lose my job because it's so stigmatized. So I offered him some suggestions. Ultimately, they weren't successful, and he ended up quitting his job. And he made me promise I wouldn't tell his mother because he was ashamed of having to quit because of his disability. Then he tried to go back to school, and he found that he could no longer hear the professors. So he had to drop out of school a second time. And then he started working in a hardware store. But again, he had trouble understanding what people were saying. And finally, he's now working in one of these 24-hour gambling parlors selling coffee and cigarettes. And this is an incredibly bright, incredibly personable person who has lost a lot of themselves. He's very depressed, he's very isolated, and he wrote to me recently and he asked me, do you think I'll ever find someone who will love me? Because I don't talk to people anymore. I'm not out in the world. And I told him, I think he will. It might take time, but honestly, I'm really concerned with him. So a lot of the times even people who are close to people who are suffering from TB, can't really see how serious the after effects are. Now, Christian never had a,
Of course.
Oh, here it is. Christian never had a hearing test. This is something that in Romania is not particularly common. His hearing loss was self-diagnosed, and that's particularly problematic because, as we know, by the time you notice that you're losing your hearing, you've already lost a pretty fair deal. So since he's missing conversation, it means he's lost quite a bit of that hearing. Now, we're lucky enough to have the new WHO guidance, which is, I briefly put the new graphic here just to show the medicines. And basically, good medicines that we know are effective and are more tolerable have been prioritized, and medicines that we know are more toxic that have a weaker evidence base are deprioritized, with a little asterisk for delaminate, because we're still waiting on where that's going to end up. So this is great news. And this is the preferred recommended all-oral regimen. It's not on an equal footing with the shorter regimen, which still contains the injectable. It's preferred. However, they're both supposed to be available, and this is one of the things that I want to focus on. Now, there's a few things that we know from the evidence, and this is from the rapid communication, that all oral regimens are effective and appropriate for most people, that DST and safety monitoring are more important than ever, particularly if somebody is going to be on the shorter regimen. And finally, that we need to have a low threshold for making sure that people are responding, and if they have bad side effects, getting them off the drugs. That means at the slightest hint of hearing loss, we need to be stopping the injectable. Now, very briefly, I'm going to go through some of the ethical values and human rights that are kind of framing this, because I'm running a little slower than I would prefer. So there's a lot of relevant ethical values. We heard Mike talking about the right to science. That's a very important one. In the same covenant, the International Covenant on Economic, Social, and Cultural Rights, we also have the right to health. And that's what I'm going to focus on today. Now, these rights are very tightly entangled. Each one affects the other, so my right to health also affects my right to be able to work, my right to an education, my right to participate in society. So we're never only talking about just one right, we're talking about the totality of these things. We've already mentioned the WHO World Health Assembly resolution on hearing loss. This is important. Countries got together and they decided that hearing loss causes a huge economic burden, and it's a great cause of disability. In fact, hearing loss is the third greatest cause of loss of disability-affected life years. So this is something that's really important, and TB treatment is creating this disability. So it's something that we have to really prioritize getting rid of. So the right to health. There are core obligations in the right to health, and these are bare minimum standards. So you can think of these as the floor. And these include, so they cannot be taken away, and not fulfilling the core obligations, essentially there's no excuse for it, including a lack of finances. If you cannot fulfill core obligations, you need to find a way to, and you have to come up with a plan to do it. So included in the core obligations is the provision of medicines on the essential medicines list. Now, every medicine that we use to treat TB is on the EML. So this should be a no-brainer. People have a right to these medicines. They're all in both the new regimen and the shorter regimen, so they need to be present in all countries. And then finally, I briefly want to mention this AAAQ framework, and I want to highlight the information accessibility piece here. Without information access, we can't have informed consent. So the way I'm interpreting this is, this includes information about one's health, information about options, information about diagnoses, adverse events, things like that. So this is absolutely crucial for realizing the right to health and having informed consent. Now, obviously, every country can't automatically provide the highest standard of health. So there's this concept of progressive realization. However, progressive realization is not sometime in the distant future. Progressive realization means that it has to be within a reasonably short period of time, as the UN interprets it, and there have to be steps which are deliberate, concrete, and targeted. And it has to be accompanied by a plan. And we have seen that there's a real absence of these plans. Now, how do we get to the full realization of the right to health? One aspect is this duty of states in a position to assist. And basically what this means is that countries which are wealthier, countries which have the ability, have a duty to assist other countries in achieving this. Now, The new DR-TB guidance provides a fantastic opportunity for states which are in a position to assist to help countries which can't roll out the new preferred regimen to do so and quickly. And I hope that both bilateral donors and multilateral donors, such as the Global Fund, will really take responsibility for this. I want to talk for a moment about the true costs. I've heard a lot of talk about how the shorter regimen with the injectable is cheaper, and this isn't correct. It's expensive. It's just not expensive up front, especially if you're not paying to do the required monitoring of hearing, which in many cases countries are not. So monthly audiometry is required with the use of the injectable, but in many places it isn't happening. So if we really think seriously about the true costs of using the injectable with the monitoring, with providing hearing aids, which don't really fix people, providing cochlear implants, which also don't restore people, as well as helping people who, like Christian, who I talked about in the beginning, can no longer do their jobs, can no longer get their university degree. The costs are enormous, and we have to do something about that. So how I want to conclude is let's think about all of these ethical principles that we've been talking about today. The right to take part in cultural life and enjoy the benefits of science, the right to the fullest health, these core obligations of having access to all of the drugs, the requirement of informed consent. Now, consent can't be informed if there's only one option available in a country. That's not informed consent. Everything has to be available, and then in collaboration with medical staff, the patient should be able to make an informed decision about what treatment and what risks are appropriate for them. So with these things in mind, then how can we advocate for the continued widespread use of the injectable, which is causing so much harm, which is creating poverty, which is creating disability, which is impeding people's employment, access to education, has alternatives, and most importantly, really, I want you to think about what you would prefer for yourself or your loved ones, because I'll be honest, I wouldn't wish that injectable upon myself or anyone I care for. In fact, I wouldn't wish it upon my worst enemy. So 2 paths are possible, and this is where I'll end things. We have the path that's going to respect human rights and the WHO ethical guidance. And that means that most people will get the new preferred all-oral regimen. A much smaller number of people will choose the shorter regimen containing the injectable. All people will make an informed choice in collaboration with medical staff. All people will get recommended DST. All will get robust ADSM safety monitoring. Or are we going to continue with what has been the standard now, which is, would you rather be deaf or dead, where the current double standards are perpetuated, where depending upon where you live, you may or may not have access to the greatest standard of care, where you have a lack of choice, you have limited DST, and you have limited or almost non-existent safety monitoring. This is a choice that we have to make. We have to end these double standards, and we have to stop using medicines which cause harm. Thank you very much.
Thanks so much, Jonathan. I don't know if anyone else was thinking of this, but when you were speaking, I was just thinking what a major gap in our standard TB